On behalf of the American Heart Association Certified Care Team and the National Partnership for Healthcare and Hospice Innovation, we would like to welcome you to today's webinar, Striving for Excellence in Heart Failure Care, Resources and Certification, where we will take an in-depth look at NPHI's Advanced Cardiac Care Program and AHA's Hospice Heart Failure Certification Program. Models share examples from two dedicated organizations providing background, available resources, and requirements to develop a program and become certified. My name is Fiona Larson, and I am the host for today's webinar. Some housekeeping reminders. All microphones will be on mute throughout the presentation, and you can submit questions through the Q&A button on your screen. Technical questions will be addressed as they come in, and we encourage you to submit your questions, and they'll be answered at the end of the presentations. Today's presentation recording will be made available after the webinar via email to all who registered and will be housed on our Palliative Hospice Heart Failure webpage. Our three speakers for today are Laura Alexoff, Marie Cunningham, and Evan Patrick. Laura is a graduate of the University of Akron College of Nursing and has been a certified hospice and palliative nurse for 12 years. She currently serves as Specialty Programs Nurse Coordinator with Hospice of Cincinnati. In this role, Laura is involved in program development and manages the operation of Hospice of Cincinnati's Advanced Cardiac Care Program for hospice patients living with end-stage heart failure and the Advanced Lung Care Program for hospice patients living with end-stage lung disease. She was active in helping Hospice of Cincinnati's Advanced Cardiac Care Program attain AHA Palliative Hospice certification and works to maintain the program's quality and AHA certification. Laura has recently become a volunteer member of the American Heart Association Hospice Certification Committee. Prior to her current role, Laura provided direct patient care for over 25 years at Hospice of Cincinnati in hospice home care and inpatient settings. Marie received her bachelor's degree in management at Arizona State University and her master's in health informatics at Northern Kentucky University. She has been with Hospice of Cincinnati for 22 years and currently serves as the manager of professional relations. Hospice of Cincinnati participated in NPHI's Comprehensive Cardiac Care Program Cohort 1 group, and Marie served as Hospice of Cincinnati's Cardiac Champion and Project Manager during the implementation and launch phases of Hospice of Cincinnati's Advanced Cardiac Care Program. She also played an important role in Hospice of Cincinnati's path to AHA certification. Marie continues to provide education to medical professionals in the community in Hospice of Cincinnati's Advanced Cardiac Care Program and the benefit it brings to patients living with advanced cardiac disease. Evan is a business development manager at Gilchrist. He has been with Gilchrist for 2 years. He serves as the point of contact for residential communities in the Harford and Baltimore counties, as well as the Baltimore City areas. His responsibilities include communication, education, outreach, and assistance to patients and families, as well as hospital and residential community staff members. Before coming to Gilchrist, he served the community for 17 years as a paramedic and emergency medicine educator with specialties in mental health emergencies, as well as critical stress resiliency. Mr. Patrick received his Bachelor's of Business Administration from the University of Central Arkansas and maintains his certification as a nationally registered paramedic and instructor. It is now my pleasure to introduce Dr. Cameron Muir, who serves as the Chief Innovation Officer for the National Partnership for Healthcare and Hospice Innovation, where he established and oversees the NPHI Innovation Lab. Dr. Muir, whenever you're ready, take it away.
Great. Thank you, Fiona. It's nice to be here with all of you. This is very, very exciting and wonderfully important work. I'm slightly biased, but we really recognized at NPHI that there was a disconnect between the high prevalence of advanced cardiac disease and the overall lack of awareness and underutilization of hospice and palliative care services. And so we really targeted advanced cardiac care as a primary focus at NPHI and began the build out of a set of resources, both for patients and caregivers, to raise education, awareness, and access, ultimately in the communities where people living with advanced cardiac disease reside, which is all across the country and the world. And then a set of tools and resources to help our member programs to really develop the competence in quality advanced cardiac care management within their programs. And so this aggregation, if you will, of a bunch of NPHI member experts constituted on the next slide, our internal subject matter experts who really were the collective intelligence of the many NPHI collections and leaders, as you heard from each of the different folks in the introduction that you'll be hearing from in just a little bit. There are years and years of experience in each of these individuals, and then across our many, many members across the United States. Dozens of folks who've really dedicated much of their career within the hospice and palliative care setting to the specific needs of the cardiac population, and really driving a consensus, if you will, of best practices all together into one comprehensive set of resources that ultimately, again, is trying to drive quality. With this driving towards quality, we also wanted to make sure we were cross-checking with the other subject matter experts that focus on cardiac care. In this case, it was with the American Heart Association. And they served, in this case, as our external subject matter expert reviewers. So what you can see is we saw a need in the innovation lab of a high prevalence of advanced cardiac disease, low utilization of hospice and palliative care, or too late, or oftentimes very late. Pulled together our collective intelligence to create a set of best practice recommendations, cross-check them with the American Heart Association subject matter experts to really bring a new standard, which then really serves as a tools and resources within our member programs to advance this excellence and this access. If you're interested in learning more about NPHI, we're certainly welcome to connect with you. What you're going to do now is hear from two different member programs from two different perspectives. The first is Hospice of Cincinnati, as Fiona introduced, and they're going to talk in just a minute about the NPHI Advanced Cardiac Care Program and how they utilize that to get ready then for what Gilchrist is going to talk in a little bit more detail about, is how that served up really an opportunity to very efficiently and effectively move through the AHA certification process to become a recognized expert formally by AHA through that certification process in advanced cardiac care. I just want to thank AHA, the American Heart Association, the leaders for their incredibly collaborative process and supporting and helping to advance the quality care ultimately for people who suffer with advanced cardiac disease, as well as the leadership at NPHI, which really has been critical to establishing these innovation lab activities. And then lastly, the leaders within the programs, both at Cincinnati, Hospice of Cincinnati, and at Gilchrist. Without your time, energy, and commitment to excellence, none of this would have been possible. So thanks AHA, thanks NPHI, and also thanks to Hospice of Cincinnati and Gilchrist. So without further ado, I'd like to advance to the next slide and turn it over to my colleagues at Hospice of Cincinnati.
Well, thank you, Cameron. So I'm Marie Cunningham, and I'm the Manager of Professional Relations at Hospice of Cincinnati. A little bit about our organization is that we started serving patients and families back in 1977. And we currently serve our patients and families in 7 counties in Southwest Ohio. And we currently care for over 800 patients a day just in our hospice program. And about 18% of those patients are enrolled in our advanced cardiac care program. And then we also have a separate palliative care division as well. So we were just thrilled to be part of the cohort 1 group when NPHI kind of put out the announcement of starting an advanced cardiac care program. And I have to honestly say that the program provider guide served as our outline and was just instrumental in helping us put together our program. So we were given that guide pretty much from the beginning. And next slide, please. So as we started on our journey and began the aggressive focus, one of the things that was outlined in the guide was to kind of put together a core committee, which is what we did. And my co-presenter Laura is going to talk a little bit more about that. But just from the beginning, just the guidance from NPHI was just beneficial. And then as being part of the cohort 1 group, we had other hospices across the country also part of that group that we were able to exchange information and share best practice and ideas and things that were working well as we were putting our programs together. And so early on in developing it, we realized that creating the buzz, both internally and externally. So internally with our team members and within the organization, we made sure that we were putting education in place and making sure that everybody knew about the talking points and kind of just got that excitement going internally. And then on a national level, I know NPHI was also doing some webinars and all that about how patients with advanced heart failure were underserved. And so we took that as well and created a fact sheet that we were taking out to our community resources and letting them know about the why were we starting an advanced heart failure program. And so that was really beneficial in just sort of teeing up the program for when we would launch it in late spring. And then again, the education was just ongoing internally. One of the things also that we identified early on were our program measures, like what were some of the things that we wanted to put in place and benchmark against. And so things like, through the guide, it talked about identifying patients sooner. And so we were looking at getting to those patients sooner and using length of stay as a benchmark, and then number of patients within our program as a benchmark as well. And so those were things we identified early on and created a dashboard. And that was super helpful then later on, so we could measure against like how were we doing with the launch of the program and then what things needed to be improved. And so next slide, please. So we did launch our program in late spring of 21 and continued with the monthly meetings with the cohort group. And about that same time frame, we were also one of 5 hospices that were working with AHA, reviewing the program requirements for their certification and providing that feedback. And I have to honestly say that as we were doing that and realizing what it took for certification, we already had a lot of the framework in place and already had the foundation for a good cardiac program just based on what NPHI had provided. And so that was beneficial for us because we knew at some point we would be seeking certification through AHA. And then as well, we were also looking at the measures we put in place, which were super helpful to help us understand what was working well, and then what did we need to improve upon. So that was an ongoing process. And one of the things we did identify was education and just the constant need to continually educate our internal team members so that they stayed on top of everything. So this is, with this program, our team members will be doing extra work. And so it is important to just make sure we stay on top of the processes so that it becomes just part of their day-to-day ingrained work. Next slide, please. So as we did our initial review after about the first several months, what we did recognize was that we did need a designated program coordinator. So the guide, the NPHI guide, does suggest that. And so when we first launched, we just had several people that were trying to fill the role, but it became evident early on, this is an essential role. So if you're looking to create an advanced cardiac care program within your hospice, just know that that is a critical piece of it. And also the team member education. It is not a one and done. And so there need to be just checkpoints along the way, revamping the education, thinking about how to continually educate your team members about the program and keep it top of mind with them. And the measures, having those in place early on really helped with accountability as well. And so knowing the specific areas that needed improvement. And as I mentioned earlier, the NPHI provided that great foundation. And as we were moving forward with our certification, that also helped us create a very comprehensive program. Next slide, please. And so we did start our journey for AHA certification in February of 22, and then did obtain that in October of 2022. And now I'm going to turn it over to Laura.
Thanks, Marie. Hi, I'm Laura Alexoff. I'm the Specialty Programs Nurse Coordinator at Hospice of Cincinnati, and I've been in this role as our program coordinator since January of 2021, which was about 4 months after we began creating our heart failure program. The NPHI provider guide refers to my role as cardiac specialist nurse, and they provide a sample job description for the role. And the American Heart Association certification manual refers to this role as program champion. Oops, I'm sorry, please advance the slides to the next one, thank you. So the AHA refers to program champion. So your organization is most likely already caring for heart failure patients, but if you decide to create a specialty heart failure program, NPHI's Advanced Cardiac Care Program is really the way to go. It'll serve as your blueprint. I mean, I can't imagine doing it without their program's guidance. You'll want to start by assembling your team. The provider guide suggests members you might want to include on your team, and some of these roles are also required for American Heart Association certification. There's the heart failure program champion, my role, at least one representative from your agency's administration, a physician or advanced practice provider, representative from nursing, social work representation, clinical educator, chaplain, pharmacist, hospice aide, finance, marketing, and others. Some of these team members, they'll be regular members of your team, and some may be ad hoc members. And then after you have your team together, NPHI guides you through creating your processes, the policies and procedures. They provide examples of these. Marketing of your program is included. It really is a comprehensive guide for building your heart failure program. Next slide, please. And as I said earlier, NPHI's provider guide is the blueprint for creating your heart failure program, but you have the ability to individualize your program. A few of the things you'll want to consider and decide. What type of patients will you accept? Inotrope patients, LVAD patients? Will you provide guideline-directed medical therapy? Cardiac comfort kit? IV push meds? What services, meds, and supplies will your program provide? For example, we provide digital scales and blood pressure monitors when our patients need those. We provide and continue GDMT and inotropes as long as the patient is benefiting from those. Perhaps initially you won't include a particular service. For example, you might decide that you're not going to care for inotrope patients. You can decide to expand your program later to include that. In our heart failure program, it's only been recently that we started providing a cardiac comfort kit. Next slide, please. This is a screenshot of the list of ICD-10 codes that NPHI provides for eligible diagnoses to be in the heart failure program. This is not the complete list. There are many more. At Hospice of Cincinnati, to be eligible for our heart failure program, the patient must have a primary diagnosis of heart failure. But your organization may decide to include all patients that have a heart failure diagnosis. Next slide, please. NPHI's Advanced Cardiac Care provider guide gives you a standardized heart failure care plan. You can use it as written by NPHI or individualize it for your organization. And then as a side note, one of the quality measures for American Heart's Hospice and Palliative Care Heart Failure Certification is that a standardized heart failure care plan be used to generate patient-specific orders to manage their heart failure symptoms. Especially valuable is that NPHI and American Heart Association's subject matter experts created 3 evidence-based algorithms for the management of heart failure symptoms: dyspnea, chest pain, and fluid volume overload. These algorithms are differentiators for your program. Cameron often refers to the algorithms as the secret sauce, and they are. The algorithms really are the heart of your program's management of your heart failure patients. Next slide, please. Another critical and very valuable component of NPHI's Advanced Cardiac Care Program is patient education, the Patient and Caregiver Handbook. All patients in our heart failure program receive this handbook. It contains all of the important education for the patient's self-care, understanding their heart failure, self-care and self-monitoring, their medications. And there's a section in the back where they can record their weights, etc. Next slide, please. And then along with the patient caregiver handbook is the critically important symptom tracker tool. It's a great visual tool for patients and caregivers to keep close at hand, posted prominently in their home where the patient and all caregivers can refer to it. It's the education they need to know to monitor themselves when we're not there and to know when to call us before symptoms escalate into a crisis. That's how we do so well at preventing ED visits and inpatient readmissions. Marie will continue with a little about our marketing efforts and about the success of our program that we've had in serving more patients living with end-stage heart failure. Thank you.
Thank you, Laura. So part of, we had this great program in place, and then
Next slide.
Next slide, please. Thank you. So some of the key elements for us in promoting our program were the local advertising. As I mentioned earlier, we created fact sheets that we took to referral sources, to the general community, and then the patient stories. So right after we started our program, we actively searched for effective patient stories and utilized several of them that we shared with the media, had them online and posted and all that. And those are really instrumental because those were firsthand stories from our patients and families on how they benefited from our program. And then we did a lot of professional and community in-services. We utilized our medical director to do one-on-one physician meetings. And of course, this just continues year after year. These are things that we're putting in place, and we're always revamping and creating new material. We also created the Advanced Cardiac Care Program brochure that we took out to referral sources. That was actually a request from them to sort of create a smaller type of brochure that they could be handing out to their patients. So that's something that we created as well. And so as far as outcomes, this program has been very impactful, and we've served a lot of patients and families. So one of the measures that we were looking at was, again, increasing our overall census of advanced heart failure patients. And so after we started our program, within that first year, we saw a 17% increase in our heart failure census for patients in this program. In year 2, it increased by 80%. And then each year it continues. And this past year, we had a 20% increase. So this program continues to grow within Hospice of Cincinnati. And also, as Cameron mentioned earlier, we weren't, overall, when at the start of this, the Advanced Cardiac Care Program through NPHI, patients were underserved. These patients were not seeking hospice care or even been told about hospice care until very late in the disease process. And so one of our goals was reaching patients sooner and looking at length of stay. And for us, again, really beneficial. In the first year, we saw an 82% increase in our length of stay for our cardiac patients, and that was huge. And then we just continue to increase year after year. And then the reductions in ED and hospital admissions, we have really, it's brought it down to zero as we work with hospital systems. And again, when you think about this patient population that is very used to they're very complex, but they're very used to just going to the ED or going to the hospital. And we saw that as very successful in the fact that we were able to manage these patients at home and avoid those ED visits and hospitalization. Okay, and now I'm going to turn it over to Steve.
Thank you so much, Laura and Marie, for your presentation. And especially, I just wanted to thank Dr. Muir and NPHI. We've worked, approximately about 4 or 5 months, getting this webinar together. But this really, as Laura and Marie shared, and as you're going to hear from Evan, this really is where, two organizations, NPHI and the AHA, it really fits together because this is an opportunity for, especially for those patients with advanced, advanced cardiac care needs, the heart failure patient population who do go on hospice to receive that specialty care. And then, the next step is that the Heart Association validates, the program that is put into place. And, as Laura shared, it really presents an easy transition if you are doing the NPHI program to move from having, a program in place to now then being able to have the Heart Association validate the program through our certification. And Evan, I'm going to turn things over to him, and he's going to go through the details on, Gilchrist program, but what it takes to ultimately end up becoming certified with their program they had in place. Evan?
Hey, thank you so much, Steve. Laura and Marie, that was a wonderful presentation. Again, I'm Evan Patrick with Gilchrist Hospice in Baltimore, Maryland area. We're very proud of our efforts that we've taken to become AHA certified, as well as undertaking the NPHI program as well. And before we jump into that journey that we went on to the certification, I just wanted to give you a little more information about our organization. We can go to the next slide. So Gilchrist is a wholly owned affiliate of the Greater Baltimore Medical Center Healthcare System, which is comprised of 3 integrated work systems. Greater Baltimore Medical Center is a 257-bed non-for-profit hospital. GBMC Health Partners employs a physician group of 300 plus primary care providers and specialists. And then there's little old Gilchrist, with providing elder and end-of-life care. This morning we had a census of 987 patients in the Greater Baltimore area, making us the largest hospice in our service area. In 2020, GBMC Healthcare became the first healthcare system in Maryland to receive the Malcolm Baldrige National Quality Award, the nation's highest presidential honor for performance excellence. Next slide, please. This year, Gilchrist celebrates its 30th anniversary as a nonprofit hospice. We're proud to be the largest provider of serious and end-of-life care in the state of Maryland and the nation's 12th largest nonprofit hospice. We are accredited by CHAP and are a recipient of the Circle of Life Award by the American Hospital Association. We always consider our reputation as our biggest asset, and we are extraordinarily fortunate to receive amazing support from our community to help fund our various programs. Next slide. In a 30-year history, of course, we have served many patients with heart failure. Going back to 2021 is when we began to embrace the NPHI's Advanced Cardiac Care Initiative. In April of that year, we formed a cardiac clinical steering committee made up largely of medical and clinical operations leaders to develop a more formal structure around our care practices, specifically related to those with heart failure. A project task list was developed and monitored monthly with tasks that range from clinical services to marketing and just everything in between. We surveyed staff regarding their cardiac care knowledge. We developed and conducted training, created dashboards, and tracked metrics. And all of that took us into 2022, and we learned about the AHA's palliative and hospice care certification and engaged with the AHA for contracting on that certification. In addition to the guidelines outlined by the AHA and in the NPHI's resources, Gilchrist's clinical program is built upon our guidelines published by our accrediting body, the Community Health Accreditation Program, CHAP, and National Hospice Palliative Care Organization, NHPCO, as well as CMS eligibility guidelines. We continuously monitor those guidelines published by these organizations to ensure our clinical practices reflect the most current care guidelines. Next slide. Why would we want to do such a thing? We were already quite successful in our area. Well, the idea was we wanted to strengthen our care protocols, really work on drilling down on our staff education and patient and family training while improving our care transitions for patients with heart failure. To demonstrate to patients, healthcare organizations, and our community that Gilchrist strives for and meets the highest performance standards in care for heart failure patients, and to expand upon our already stellar reputation and further augment our credibility with our referral partners. Next slide. The AHA certification consists of 6 standards which form the foundation of the program. Each of these standards is informed by the others, setting the standard for a multifaceted, well-integrated plan of continuous improvement. Requirement 1 is one of program management. There needs to be oversight of the heart failure program and the interprofessional committee that provides this role, that plays a key role in assuring all the requirements are met. Proudly, I am one of our program champions that was earlier mentioned by Marie. Requirement 2 is for staff education. It is extremely important that staff working with these patients have extensive knowledge for the heart failure patient population, for the symptoms that they will be enduring, and for the likely trajectory that they will be following. Requirement 3 is for the patient and their caregivers' education. Heart failure is a deeply complex disease process, as we know. It's very important that we provide the proper education to the patient and their caregivers, and also assess their readiness and ability to learn more about what they're going to be going through. Requirement 4 is for care coordination. This is probably the most complex requirement, with the focus on identifying and receiving patients from referral sources with the proper information, caring for the patient properly while under our care, and ensuring there is proper communication upon the patient being transferred or discharged from our care. Requirement 5 is for clinical management, making sure all the aspects of care, including the pathways, algorithms, order sets, they're all based on evidence-based guidelines, so that we always know that we're doing the proper thing for the proper reason. Requirement 6, performance improvement. One of my first bosses told me, you got to get better at what you do every day. So quality improvement is a key component to continually evaluate and improve care and outcomes. This is done through measures and metrics that are tracked and reported upon on an ongoing basis. Next slide. This slide depicts the journey for an organization going through the certification process. The first step is to get contracted with the AHA and begin working through the process. Next step is taking your heart failure program and work with the AHA staff to see how the components already in place meet the standards that we covered in the previous slide. Once the T's are crossed and the I's are dotted, the evidence of meeting the standards are uploaded into the certification portal for AHA review. Once the desk review is performed and completed, a virtual presentation is done and the organization becomes certified. This is a 3-year certification with an ongoing annual check-in from the AHA. The next slide I'm going to show you demonstrates how our program specifically met these standards. Next slide. This is our heart failure program committee member list, and you see that we brought together many disciplines to form our heart failure program committee. We met together weekly or sometimes bi-weekly for the past several months. We've now shifted to a monthly committee meeting where we review our dashboards and develop and monitor strategies to continue improving the services we provide for our heart failure patients. During the next 6 months, we'll also focus heavily on marketing the program to serve more people who need our care. The AHA assist in this by providing a program consultant to assist with marketing to our outside healthcare systems that already have an AHA connection. The committee has shifted slightly to ensure ongoing education and ample physician support. Next slide. Our current education policy has been implemented for specific orientation and ongoing education of all staff related to the management of heart failure patients. The Gilchrist policy requires training that is delivered for all patient-facing staff during the new hire orientation and during annual competencies. It must be consistent with the scope of services for nurses, social workers, chaplains, and hospice aides, and must be supported by a learning management system for compliance monitoring, as this will also be reported to the AHA. Next slide, please. Our education is targeted specific to the staff depending on their individual disciplines. Chaplains and hospice aides will gain a general understanding of heart failure, how to identify a patient in distress, and signs and symptoms of the dying patient. Social workers received education on the psychosocial aspects of heart failure management to help reduce risks for ED visits, hospital readmissions, and revocations or discharges from our service. They also received education on the signs and symptoms of the dying patient. Our nursing staff received specific education on the overall initiative of our program, clinical assessment and management, and the changes made to the clinical documentation necessary for the program. This included use of the clinical resource guidelines for cardiac patients, a prognostication book to help with eligibility, family and patient education guides, review of heart failure and the common trajectories the disease process can take, as well as a framework to discuss short length of stay scenarios in the case of MI, cardiac arrest, or death. Our providers were also given the same education on the overall initiative for the program, clinical outcomes, and treatment strategies. Next slide. The NPHI's Advanced Cardiac Care Program booklet was already in place by the time that we began to initiate contracting with the AHA. And as you heard earlier from the Cincinnati presenters, we had things like advanced care planning, patient eligibility parameters, ICD-10 codes, clinical algorithms, all the way through specific mechanical intervention education for LVADs and ICD and pacemaker devices. It's an incredible resource and one that we're proud to have both in print and online through our website for those patients that need it. Next slide. When we enroll a patient, regardless of their prognosis or diagnosis, all of our patients receive the hospice caregiving book that you see on the left side of the slide there. The goals of care, advanced directives, and MOLST review is initiated at time of enrollment. And as we have identified them either through the referral questionnaires or at time of admission, if they are appropriate as a heart failure patient, we will also supply them with the NPHI booklet. Next slide. During the initial referral process, our Access Center coordinators will use a referral checklist. Gilchrist has incorporated a heart failure patient section for questions geared to this diagnosis group. An access nurse will facilitate patient admission appointments based on this information. Depending on the referral source, be it a provider's office, hospital, patient, or their family, the access coordinator may have to follow up with the patient's cardiologist or medical provider to obtain more baseline information. This level of detailed patient information collection upon referral allows our staff to provide adequate care for our heart failure patient population at time of enrollment. Next slide. Standardized care plans are added based on assessed patient needs and symptoms. As we know, heart failure presents myriad of ways, and not every care plan is necessary for every patient. So it's really more of a menu of how we're going to be treating each individual patient as an individual. Care plans can include cardiac assessment with specific vital sign and pulse ox parameters, comfort care and symptom management kits, teaching, training, coaching, use and goals of care for cardiac devices like AICDs and LVADs, as well as how we're going to be addressing any assessed knowledge deficits. Next slide, please. For our hospice enrollment, we're fortunate enough to have multiple service lines with which we might be able to capture somebody in different areas of their prognosis. But it all begins with a clinical assessment by an RN liaison in a hospital or an access RN in a home or RCC. Eligibility review is conducted by a hospice physician with input from that same RN, and that physician determines the primary hospice diagnosis. The access RN at that point either enrolls a patient using the cardiac checklist and begins patient education and initiates a care plan, and then passes that on to our local IDT interdisciplinary teams for their comprehensive assessment and ongoing care. What you'll see during the eligibility review is that we have a chance to continue to capture patients that we may not find as eligible for hospice at this time through the use of either our palliative care outreach or a in-home primary care practice that we refer to as elder medical care. This is for the elderly homebound patient to make sure that we're supporting them and keeping them out of a health system or a health care free fall due to their inability to get to regular appointments. Next slide. Care coordination is led by a nurse case manager who oversees care of the patient every day and coordinates delivery of care by the IDT. In essence, their role is to document what has happened in the last 2 weeks, provide an overall assessment of comfort and eligibility using both subjective and objective measures, and predict needs for the next 2 weeks. Specific roles of the case manager is to monitor the patient for changes in condition, communicate with the hospice physician and the AOHR, attending a hospice record, and obtain orders for changes to the care plan. They will also supervise care provided by the hospice aides and generally quarterback for the IDT to ensure that all members are delivering exceptional and integrated care. Next slide. Not everyone will remain eligible or even choose to remain with us on the hospice benefit. Our goal with internal transitions between service lines is to functionally close an episode in one service line while simultaneously opening another in the targeted service line, whether it be palliative, hospice, or elder medical care, or back and forth between those programs as the patient's prognosis and goals of care change. External transitions are assisted with a warm handoff tool, helping to ensure we've addressed all aspects of care delivery, including contacting the patient's PCP and any other provider organizations, adequately communicating patient status, and sharing documentation that may be needed for additional DME or supplies. Next slide. This is a look at our clinical reference guidelines. This is online available for all of our staff members. As you can see, it's quite exhaustive, and our providers, our nurses can jump from topic to topic or go searching for individual things, such as, next slide, our ventricular assist devices page, which you can see is broken down into things as basic as terminology. Next slide. Our clinical pathways allow us to pinpoint where a patient may be in their diagnostic progression within the heart failure program, within the heart failure disease process, and isolate individual symptoms and treatment algorithms for us to follow. Next slide. Our success with this, even just in the short time that we've been certified, is that we've seen a 46% increase in heart failure admissions within just a year's time, going from 8% of our total census with a diagnosis of heart failure to 12%. Averaging, our length of stay has increased over a year's time, and we're working on getting referrals earlier due to this disease process. We've heard already from Dr. Muir and Laura Marie, underserved this population, and they're just not aware that this may be something that may be beneficial to them. We've also seen the volume of live discharges versus death fluctuate with an average of 16%. And this has really kicked off a really interesting conversation that Gilchrist may not have had otherwise, because this definitely wasn't a metric that we were tracking that we wouldn't have known to track without the framework of the AHA. By reporting this data back, we were able to kind of begin to drill in on what does this mean for us? What does it mean for the care that we're providing? And we've already taken some of this back to those IDT teams that are actually providing the care and asking their opinions and trying to get more information on what this means. Is it something that is important? Is it something that we can prevent? And what does it mean for the care that we provide? Next slide. In conclusion, Gilchrist has become stronger while preparing for the AHA accreditation. Formalized consistent protocols, staff education, patient and family training while improving our care transitions for patients with heart failure. We've developed standardized measures for reporting, driving strategies, and improving quality performance. We are excited to share the outcomes with the AHA and to contribute towards national standards for evidence-based care of patients with heart failure and their families. We look forward to promoting AHA certification of our palliative and hospice care programs. Thank you.
Next slide. So, Evan, thank you so much for this presentation. Unfortunately, we are not going to be able to take questions and answers at this point in the webinar. However, if you go to the next slide, we have put several email addresses up there. If you want to talk to Laura or Marie or Evan, or even to get more information about the certification, you can email us, and along with information about NPHI. You know, again, if you're not an NPHI member, I would highly encourage you to join. If you are interested in pursuing certification and taking that next step, please don't hesitate to reach out to us. You know, as you know, both organizations very much are collaborative and walk alongside you towards this journey to be able to really work and improve quality of life for heart failure patients. Dr. Muir, any final comments?
Steve, I would just thank you and your colleagues at AHA. You know, ultimately, I think all of us come together around the fact that people who are needlessly suffering today with advanced cardiac care, thanks to our collaboration and the expertise that Laura, Marie, and Evan shared with implementing these tools and resources and then getting certified, you know, is just such an encouraging way to think about reducing suffering, you know, tomorrow in all of our communities and across the United States. So I just want to say thank you to all of you at AHA, and thanks to our presenters. The statistics that you shared around improved access and improved quality of care is just why we at NPHI, and why I in particular as a physician, just love doing this innovations work, because you just can see more people getting better care. And at the end of the day, isn't that what it's all about? So thank you, Steve, and your colleagues at AHA, Fiona. Really appreciate all of you.
Thank you, Dr. Muir. And Fiona, do you want to close this out?
You got it. Well, I'd like to thank our presenters, Marie, Laura, and Evan, along with Dr. Cameron Muir, for leading today's webinar. And thank you all for your participation in today's event. On behalf of the American Heart Association and the National Partnership for Healthcare and Hospice Innovation, we thank you for joining us and have a great day. This concludes today's presentation.